So our next speaker is Dr. Dedwani, and I will ask Dr. Nitin Doshi to introduce him. Dr. Doshi, as you all know, is one of our cardiologists over here. He is a cardiovascular surgery in charge, CCU in charge, and also he is the medical director of the CHF program at St. Joe Hospital. Nitin.
Thanks, Usman. The next speaker I'm going to introduce is a very good friend, and I've known him for over 30 years. First time we met was in San Diego, where we were attending a ECHO conference, and since then he got into a lot of research activities as well as academics, and that resulted in he being author of numerous publications and also primary investigators. He has chaired so many national, international, as well as American College of Cardiology section meetings on hypertension, as well as congestive heart failure, as well as hyperlipidemia. All his work, if I enumerate, it would take entire his time of 1 hour that I'll be taking it, so I will not go into that. But he is one of the most recognizable figures in the field of diabetes, hypertension, heart failure, lipid disorders as relate to cardiology. Presently, he's a professor of medicine at the University of California, San Francisco School of Medicine, and director of heart failure program at University of California, San Francisco program in Fresno, California. He's also director of cardiovascular research for the same place, Fresno Central San Joaquin Valley Medical Education Program, and clinical professor of medicine at Stanford University, Palo Alto. He's a fellow of numerous societies, just to name few: American College of Cardiology, American College of Physicians, American College of Hypertension, as well as member of the American Society of Thoracic Society and American Federation of Clinical Research. He is currently president of the California chapter of American Society of Hypertension, and he's a past president of International Society for Holter and Non-Invasive Electrocardiography. And he has served on national committee, several committees that really define all the guidelines for College of Cardiology and American Heart Association. And he was also a member of the several writing groups, including the American College of Cardiology, American Heart Association practice guidelines for chronic stable angina, as well as ambulatory ECG monitoring. So it is my privilege to introduce you my very good friend, Dr. Prakash Dedwani.
Well, good morning. Thank you, Nitin, for those kind words. It's indeed a pleasure for me to be here. Obviously, I'll give you a little bit of a perspective on heart failure and where I am today. I've been involved in heart failure for 35 years, a long time. I've seen the evolution of all of the drugs, including vasodilator, ACE inhibitor, ARB, beta blockers, milrinone receptor antagonist, and many newer drugs such as ivabradine and vasodilator therapy with sacubitril that Wilson is going to talk about. I will give you an introduction of heart failure by saying, as you heard already in the previous talk, heart failure is worse than many cancers. And the only way we can contain heart failure is by preventing it, as you heard in the previous talk. And this is why, even though I'm currently director of heart failure and advanced therapies for heart failure, I'm focusing more and more on prevention, because I have realized in 35 years that we can only do so much in patients once they develop heart failure. So really, we must begin early, and as you said very correctly, the risk factors that really cause cardiovascular disease in general, particularly hypertension, is probably one of the most important factor to control, and it's so easy to control early on if we get proper guideline and proper direction, which we hopefully will get now. As you already heard, that heart failure events are increasing. It's a disease of the elderly. It is a disease that is going to progressively increase. It is projected from the numbers you showed, about 6 million. The number will be about 9 million by end of 2025. Also in this diagram, you can clearly see that the people or percent of people above 75 years that develop heart failure is astronomically high, as much as 25 to 30 per 1,000 person years. And these numbers, as you know, are increasing with baby boomers aging, with a lot of elderly people living beyond the expected years because of the longevity post-MI, because of the longevity of patient with hypertension. A journey of patient who develops heart failure is unfortunately very cumbersome, and it's a journey that really begins early on just with the initial symptoms and signs of heart failure. But if we don't use appropriate therapy, this is a journey that's a downhill path and clearly leads to, as you heard, repeated hospitalization. To emphasize the importance of this, I want to show you this front page or the opening page of JAMA in January of 2013, which shows that heart failure patients are frequent flyer, not on the airline, but to the hospital. Clearly, this is generating major revenues for the hospital, but unfortunately, it's now also causing a lot of penalties for hospitals that have this repeated hospitalization. As you already heard in some other way, that this is from my friend Mike Giorgetti, that each hospitalization of heart failure patient is indicative of worsening function and increasing mortality of these patients. It has been shown that every hospitalization that occurs in heart failure patient increases mortality by about 20%. We know that inpatient mortality is already very high in these patients in the first 6 months and continues to increase. And I already mentioned it's a disease of elderly, and we are likely to see a lot more in patients who have diabetes, obesity. They are increasing in incidence, and along with them comes also hypertension. So talking about the pathophysiology of heart failure, it's really no different than the ordinary chain of events that was described many years ago by Victor Zhao and Jean Braunwald, that with the presence of risk factors, you have the development of disease processes, whether it's heart failure directly due to hypertension related to left ventricular target and organ damage, or development of atherosclerosis leading to myocardial infarction, and subsequently the consequences of post-MI, remodeling, arrhythmias, LV dilatation, dysfunction, and heart failure. So this is from the Framingham study, which has taught so much to us about heart failure. Dan Levy and other people have published this kind of thing. This is just to present to you a unifying hypothesis of heart failure. Hypertension as a singular disorder can lead to both diastolic and systolic dysfunction in heart failure. On the one hand, hypertension leads to pressure overload hypertrophy, left ventricular hypertrophy, and this is considered as one of the very powerful predictor of subsequent development of heart failure. On the other hand, many hypertensive patients have coexistent coronary risk factors that increase the risk of myocardial infarction that subsequently leads to loss of ejection fraction or systolic function and developing heart failure and death. But as was emphasized in the previous talk, heart failure doesn't develop overnight. It's a disease that progresses over time. It's a disease that has many stages, and this is why the ACC-AHA heart failure guidelines have emphasized the treatment of heart failure at stage A, which is nothing but the presence of all the risk factors that causes subsequent development of LV dysfunction and leading to heart failure. Now let's talk directly of the heart failure pathophysiology. Whatever causes the myocardial injury, whether it's a myocardial infarction, whether it's uncontrolled hypertension over time, whether it's some sort of toxic thing such as substance abuse, meth abuse, and cocaine are becoming increasingly prevalent. I don't know how it is here, but in my heart failure center, 30 to 40% of the patients are with substance abuse. So that is becoming a major concern as well. Whatever the cause of injury then leads to neuroendocrine activation, and we'll go over in some detail. This is renin, angiotensin, aldosterone system activation, sympathogenic activation that then causes further damage by direct myocardial remodeling, myocardial toxicity, further progressing LV dysfunction, disease progression, and then in between you have development of hemodynamic abnormalities that then leads to exercise intolerance, and in many cases, unfortunately, progression of symptoms and hospitalization. So this you can see, if you look at the same schema now, you can see the neuroendocrine activation are very, very critical in the entire process of LV remodeling and heart failure. And when we talk about neuroendocrine activation for all practical purposes today, based on the therapeutic aspect, the two neuroendocrine axes are very important, renin-angiotensin, and now you can add in between aldosterone system and sympathothermic system. You can see that both of these hormonal axes produce peripheral vasoconstriction, cause hemodynamic alteration, as well at the same time, they lead to changes in the tissue characteristics, fibrosis, programmed cell death, which is called apoptosis, hypertrophy, except this hypertrophy is many cases post-MI eccentric, not concentric hypertrophy, and then, of course, myocardial toxicity, particularly by activation of sympathothermic system, because catecholamines in excess are very toxic to myocardium. And this then leads to the process of LV remodeling, which causes progressive LV dilatation and LV dysfunction. So here we can see, as was already emphasized, that when we look at the risk factor for heart failure, we must distinguish what are considered population attributable risk versus relative risk. When we talk about population attributable risk, both in men and women, number one risk factor is hypertension. What do we mean by population attributable risk? So if you went outside your hospital to 100 people walking in front of the hospital and looked at incidence of heart failure and related it to presence of risk factor, it's a hypertension because it's so much more prevalent in society. With the older criteria, we have 70 plus million people. Every third American has hypertension. And if you add other things such as diabetes, every other American has one or the other thing. So this is a very, very significant problem. Myocardial infarction is also a very, very important population attributable risk, particularly in man. But when it comes to relative risk, myocardial infarction is much more important than hypertension because it's already associated with damage to the myocardium. So cardiac remodeling, which is an intermediate process before you develop LV dysfunction and heart failure, is very, very critical. It's critical for two reasons. Number one, it is something that we can prevent if we intervene early enough with proper neurohormonal antagonists. It is something that subsequently, if uncontrolled, will lead to progressive LV dysfunction even after an individual has developed heart failure. And all of these are the consequences of LV remodeling. And you can see here that many conditions are associated with LV remodeling process, such as post-myocardial infarction, such as myocarditis, such as anti-cancer drug, substance abuse. Ethanol used to be a major cause, but now it's actually other substance abuses, such as the recreational drugs these days. Although cardiac remodeling has been characterized in experimental models as post-MI and cellular mechanisms that ultimately result in cardiac structure alterations and functions, we know that regardless of whatever etiology, not just post-MI, it is the same process that goes on in other situations. And of course, as I mentioned, the consequences of LV remodeling are LV dysfunction and subsequent dilatation and heart failure. So here's a model that Mark Pfeffer, when he first described post-myocardial infarction remodeling, put together in a simplistic way. So once we have infarction, of course, we have a dead part of the myocardium. In few days, we have infarct expansion that causes sort of aneurysmal dilatation or LV dilatation. That then leads to remodeling, which, as you can see, leads to change in the shape of the ventricle, as well as what we call eccentric hypertrophy. So that is not a geometric shape of the ventricle that is maintained. It actually changes, and that all leads to perpetuating LV dysfunction. Well, many studies have shown, this is a Framingham study again, that showed that in people who develop myocardial infarction, such as here in these two curves, blue and yellow here, male or female, compared to the matched age and gender matched individuals who do not have myocardial infarction, you can see the heart failure risk is substantially and progressively increased related to the myocardial damage that occur post-myocardial infarction. Well, when we talk about pathological factors that are related to the cardiac remodeling, in addition to the increased wall stress that occurs because of the change in the geometry of the ventricle, there are neurohormonal factors, the same factors I mentioned to you, but there are additional ones. Angiotensin II, a result of the activation of renin-angiotensin system, aldosterone release, which you heard before, with dilatation of the ventricle, with any abnormal situations, and also by stimulation of aldosterone release by Ang2 as well as catecholamines. You have high levels of aldosterone, and we have recognized the critical role of aldosterone in myocardial fibrosis, which is how the mineral receptor antagonists work, not by their diuretic effect. And then there are others that are less understood. We know their role in pathophysiology, but we do not have any good idea of blocking them and positive effect. These are endothelin receptors or activation and other cytokines such as TNF-alpha and inflammatory cytokines. So just to show you that these hormonal activations occur even in asymptomatic state, this is a classic study, the SALT study that you heard of. Gary Francis did a neurohormonal evaluation in control people that were admitted without MI in the ICU or CCU. He measured their plasma norepinephrine, plasma renin activity, ANF, or what we will today call the BNP, and the vasopressin, arginine vasopressin. And you can see, as compared to the control who did not have cardiac dysfunction, even early stages in patients who were in prevention arm, in other words, those who did not have heart failure but had evidence of LV dysfunction, already the levels of norepinephrine and more so in levels of renin activation with heart failure have increased, ANF levels have increased, and also arginine vasopressin, suggesting that neurohormonal activation is very much involved in the process of LV remodeling quite early on, and the blockade of these neurohormones will be beneficial even before the patient develops the clinical signs and symptoms of heart failure. Well, there are tremendous amount of interaction between neurohormones that we don't fully understand, but we have better and better understanding each day about them. First of all, catecholamine release also stimulate the release of plasma renin activity. There is a crosstalk between renin-angiotensin system and catechol or adrenergic system. Angiotensin II, on the other hand, also stimulates the release of norepinephrine from the sympathetic nerve endings, right where the action of the hormone is. Angiotensin II also stimulates production of endothelin, the most potent vasoconstrictor by cardiac cells as well as by endothelial cells. TNF-alpha increases cardiac fibroblast AT1 receptor density, which is critically involved in the myocardial fibrosis and subsequent LV remodeling processes. So I'm going to shift now and talk about the basic treatment first, and then you will hear later on also about the emerging therapies by my good friend Wilson Tang. So we have plenty of data about the benefit of ACE inhibitors, and there is no other class of drug that is more beneficial in treatment of heart failure, even in the early asymptomatic stages and certainly in symptomatic stages, than RAS-blocking drugs. So here we have a summary of the pooled analysis of 32 randomized trials on total mortality, on deaths due to heart failure progression, or combined death or hospitalization due to heart failure. And you can see that ACE inhibitor group, the groups that were treated with any kind of ACE inhibitor in therapeutic doses, had substantial reduction in mortality, substantial reduction in deaths due to heart failure or hospitalization due to heart failure, all of these being quite significant. And this has led to the establishment of RAS-blocking drug as the first line and mandatory therapy in all people. And these are some of the trials that have really been the landmark studies. Consensus was in class 4 heart failure patient, one of the first trials showing the benefit of ACE inhibition with enalapril, and you can see the curves separate quite early, within 2 months, and continue to diverge. Then we have the SALT trial, which was the NIH trial you heard about, very highly significant difference. And then we have a post-myocardial infarction trial that was based on the process of LV remodeling done by Mark Pfeffer, and again showing captopril in the post-MI setting, showing substantial benefit. And then we have some trials that provide weak, nonetheless beneficial effects of angiotensin receptor blockers. The best data comes from the CHARM, reduced ejection fraction trial, that showed that on top of ACE inhibitor, in those who are symptomatic, if you added angiotensin receptor blocker candesartan, there was a substantial reduction in mortality and heart failure hospitalization, and also some weak data, but nonetheless beneficial data from the valsartan trial, the VALHEF trial. But remember, these trials were done, particularly VALHEF was done prior to beta blocker being a standard therapy, and that might have caused some wrinkle here. One of the major problem with this standard therapy today is in primary care still, most patients are not getting the dosages of these drugs. This has been proven time and again, and one of the reasons, as alluded by Tom, is that some people see borderline renal dysfunction, which is present in almost 2/3 of the patient, as a relative contraindication or as a worrisome thing, and they don't want to start patients on RAS blocking drug. That actually is a mistake, both for heart failure as well as for renal function. Starting RAS inhibitor is the most appropriate thing, and one should not worry about a little bit of the bump. I usually say, as long as the creatinine is not above 3 or not increased by 50% or more, one should not worry about it. We were talking about hyperkalemia, Wilson and I were talking about it. We don't worry about hyperkalemia unless the potassium goes above 5.5. And a practical dictum here is that if your patient is showing an increase in serum creatinine or BUN, that means you are giving therapeutic doses of RAS inhibitor. If it does not increase, that means you are in subtherapeutic range. So actually, most nephrologists will say that's the way to judge if you are using proper doses or not. Look at the dosages that have been shown to be beneficial, and doses that were used in the clinical trials. They are not 12.5 milligram BID or TID of captopril. They are 50 milligram TID. And also average dose in trials was about 123 milligram a day. And nalopril, up to 20 milligram twice a day. And as you can see, the mean dose was slightly lower, about 17 milligram. And same thing applies for all these others. The point I want to emphasize is that we should be using these drugs in a lot higher doses than we are using to really provide the benefit that has been shown in the trials I shared with you. So let's switch gear and now talk about the other basic drug, that's beta blocker. Why are they so beneficial? Well, because long-term data, many years ago, almost 20 years ago now, has shown that clearly when we look at the plasma norepinephrine level, this is from the VALHEF study, higher the plasma norepinephrine, the higher or greater the mortality in the patients with heart failure, and many patients have levels that are in this range of plasma norepinephrine. And as I have mentioned to you to some extent, but specifically talking about the direct effect of catecholamine axis, it is predominantly involved in cardiac remodeling by promoting the growth of myocytes and fibroblasts, thereby increasing fibrosis, which is one of the major processes of losing cardiac function. Myocyte necrosis, whatever living myocytes are there, with higher levels of catecholamine, there will be further necrosis and programmed cell death that result in further loss of myocardial cells. And they are very arrhythmogenic, both for atrial and ventricular arrhythmia. And as such, we have found that in patients who have ventricular arrhythmias or AFib in the setting of heart failure, the best drug are beta blockers still, not antiarrhythmic agents, which have killed many people in the past 20 years. And beta-adrenergic receptor downregulation occurs, and this is one of the major reasons why we give beta blockers, because that further causes upregulation of beta receptor, and this is why ejection fraction improves when we give beta blockers. Contrary to what we have been told in medical schools that beta blockers have negative inotropic effect, we know in all of the studies that ejection fraction actually improves after the long-term administration of beta blocker. In many cases, ejection fraction is normalized in a lot of studies that we have been involved in. And clearly, as you can see here, when we talk about the increased sympathetic outflow, the consequences are, of course, increased cardiac sympathetic activity and all of the effects on beta and alpha receptors. But also, in addition to that, this increased sympathetic activity has adverse consequences on renal physiology, which you heard already from Tom Haywood earlier, that it can cause vasoconstriction and also be involved in cardiorenal syndrome. And we have many studies. I'm not going to show you in detail, but just the summary slide here showing that the 3 major trials that have evaluated the role of beta blockers, specific beta blockers, not all beta blockers, have shown universally No other no other pharmacologic agents have shown such universal efficacy. 34% reduction in mortality due to heart failure or overall mortality in all three of these trials, carvedilol, bisoprolol, and also merit heart failure with metoprolol succinate. But these data do not apply to atenolol. These data do not apply to short-acting metoprolol, which is a mistake. Many a times pharmacy in the past used to say, well, you can give atenolol because it costs less. Well, atenolol is a very short-acting drug. It only acts for about 6 hours, 7 hours, we have shown many years ago, and it causes what I call the beta blocker withdrawal. That actually puts the patient at higher risk of arrhythmia and beta blocker escape phenomenon. So it's actually dangerous. Same thing for metoprolol short-acting ones. So if you want to simulate the results of these clinical trials, we must use one of these three agents. Metoprolol succinate is now generic. Carvedilol is now generic. Carvedilol has to be given BID, and it's not a cardioselective agent. And bisoprolol is not approved in the United States for heart failure treatment, so it's mainly a European drug for heart failure. Again, the doses of these agents is very, very concerning. A repeated number of surveys in heart failure treatment strategy in hospitals and practices have shown that very rarely do you use dosages, for example, metoprolol succinate in 200 milligram once a day. Most people stop it at 100 milligram, and that certainly won't give you the results that one should want. In Merit Heart Failure trial, where I was the PI for US with Steve Gottlieb, our average dose was about 160 milligram a day. Carvedilol, the average dose in trials was 37 milligram a day given BID, and bisoprolol about 9 milligram a day in the clinical trials as well. The next agent that is standard of therapy, has become a standard in the last 2 years, is aldosterone receptor blockade, what we call MRAs, mineraloreceptor receptor antagonists. So we talked about angiotensin 2, we talked about norepinephrine, and in between we have the high levels of aldosterone. Actually, aldosterone higher levels do very similar thing, except it is probably the most specific and more potent agent for causing fibrosis and also arrhythmias and also perpetuating ischemia. And we now have trials, both in advanced heart failure that we studied in the RALS trial, Burt Pitt pioneering this concept, that clearly when patients were treated with spironolactone, which cost a nickel a day, where there was a substantial reduction, 30% reduction in mortality and hospitalization for heart failure. But in more recent data from Emphasis Heart Failure, which was done with eplerenone, which is a more specific aldosterone receptor antagonist, does not cause gynecomastia, which we saw as a problem in 8% of patients in RALS study. This was a trial done in Europe, but now it's accepted in guidelines here as well, that in class 2 heart failure patient, that is any patient who has symptoms of heart failure, aldosterone receptor blocker is also quite beneficial. So I think aldosterone receptor blocker is also now widely accepted in guidelines, and I'll go over that in a minute. And some of the practical points about MRA, we should start low and go slow. And this is predominantly for the risk of hyperkalemia and some worsening of renal function. The dosages for spironolactone is 12.5 to up to 25 milligram a day. Don't increase it beyond 25. I have seen many enthusiastic heart failure nurse practitioner increasing it to 50 milligram a day. There is no evidence that that really provides substantial benefit unless you have some specific other reasons such as hypokalemia, etc. in these patients. Eplerenone is starting also in 25 milligram a day, and the target dose is 50 milligram daily. We don't use eplerenone too much in this country, even though it is now generic as well. Most people use spironolactone, and certainly you should be cautious if patient has marginal renal function and if patient has hyperkalemia. The guidelines suggest that if your baseline potassium level is more than 5, you should either not start MRA or start MRA with very cautious monitoring of the potassium levels. This probably will change because last month, one potassium binding resin was approved, and in 2 or 3 months, another one is coming on the horizon. So hyperkalemia will not be a limitation now. If you want to give to the patient who have high baseline potassium, you can either start them on these potassium binding resins or start your MRA And if the potassium goes up to a dangerous level or what you would consider uncomfortable level, then you can go ahead and use the potassium binding resins. And you can see here that there are guidelines here to avoid what one would expect some sort of concerning consequences. And this is on days 2, 3, and 7 after MRA initiation, you should monitor potassium levels and renal function, more so in people who have borderline renal function and borderline potassium to start with. And then after that, every month for about 3 months, but after that, you don't need to do it other than 3 or 4 months every time. So when we talk about treatment of heart failure, decreasing hospitalization and mortality, clearly it's quite obvious that beta blockers and RAS blocking drugs are highly effective. So when we are treating our patient with heart failure, what are the goals? Well, I'm showing this because it's still many people think the goal is to relieve congestion. Well, that is an important goal for both patient and clinician, but that should not be the only goal because particularly heart failure being worse than many cancers, we want to increase the patient's survival as well. So yes, symptoms we can reduce by many drugs, none of which have been shown to have any positive effect on mortality. Diuretics, salt restriction, digoxin is not recommended now in most of the cases for the reasons you heard earlier. But when we talk about other drugs that I've discussed with you, RAS blocking drug, beta blockers, aldosterone receptor antagonists, and now to add to this CRT, which again Wilson will talk about, these are the interventions that also will slow or prevent the disease progression. So they are very critical to prevent further progression of patients with LV dysfunction or heart failure. And of course, on the right-hand side is what is of most benefit, that is decreasing mortality or improving survival. And you can see all of these agents are listed here. And these are RAS blocking drugs, beta blockers, aldosterone antagonists in a specific population that you may see quite a bit here, African American people, the isosorbide dinitrate hydroxyl combination, and then CRT and ICD in appropriate patients as well. So this is actually the one chart that I recommend for those of you who are not heart failure specialists to keep in your office or in your pocket. This is the latest guideline chart, and this chart states everything that I've told you or anybody will tell you. Heart failure is stage A, you already heard about. This is the caution. This is the largest population that is at risk of developing heart failure, and the treatment is predominantly the modification of risk factors and certain specific therapies that could be more beneficial than other in these patients. Stage B are the patients who have LV dysfunction that are at very high risk of developing heart failure. And here again, we have a specific agent such as ACE inhibitor and beta blockers post-MI setting that could be highly beneficial. What I'm talking specifically now are stage C, or the symptomatic patients with heart failure, where there are specific therapies that we have already discussed, but I'll go over the guideline recommendation. We'll not be talking about stage D because it's actually a separate kind of discussion, but I think Wilson is going to touch upon that to some extent about what advanced therapies we have available for these stage D patients. So this you can see, this is sort of again another simplistic diagram from a review article that Mariel Jessup wrote some years ago in New England Journal of Medicine. And clearly it emphasizes that and you heard a very, very important point from previous speaker, that you cannot go back in general in heart failure patient. You can prevent progression, but you cannot reverse back. So whatever damage occurs, our goal is to prevent the damage from the very beginning. And this is keeping in mind with the treatment of patient with stage A and B. When we talk about a stage C, and that's what I'm talking about, patient with obvious clinical symptoms and signs of heart failure, we clearly must contain it here, because if not, then there will be a rapid downhill slope. And I already showed you that benefit of ACE inhibitor therapy and then benefit of beta blocker therapy. You can see that this is looking at the annual mortality, 1-year mortality. So in the people that were not treated with ACE inhibitor, this is from the first trial, the SALT trial, you can see the annual mortality is somewhere around 16%. You can decrease that by 23% by using ACE inhibitor. To this, if you add the beta blocker, you can decrease it further, if you remember now, by 33%, 34%. So that mortality is now already reduced to 50% of what it would be without either of these two classes of agent. And there is some evidence that when patients are still symptomatic, you can further reduce it by using ARB, but this concept is now changing because now we are adding aldosterone receptor blocker with a more effective reduction rather than with the ARB. And specifically to some of your patient population, African American patients, we have a unique treatment here. This was a study done based on some of our trials that we had done in VA, the VHAF trial, in which there was a unique effect seen in African American patients. And based on that hypothesis, this trial emerged. And this was a trial done specifically in self-described African American patients who were still symptomatic on the standard therapy with RAS blocking drug as well as beta blocker. Then they added isosorbide dinitrate and hydralazine as a fixed combination, and they found astonishing data that within about a year, there was a surprisingly, unbelievably great benefit in favor of isosorbide dinitrate plus hydralazine on top of standard therapy. Mortality was reduced by 40% in these people, and clearly you can see that this was a significant absolute risk reduction as well of about 4% on top of standard therapy. So this has now become a standard regimen for African American patients, which I know you see many of them around here. And here you can see from the guideline directed treatment, when you have patients with symptomatic heart failure, every patient should be on ACE or ARB and beta blocker. This is a class 1 level of evidence A. You have no better or stronger evidence than that. So every patient, unless you can find a reason, should be on these drugs. Then for specific patients that are volume overloaded, you can add diuretics. A word of caution here, every patient with heart failure does not need to be on a diuretic. This is another mistake quite often I see. Word heart failure is not synonymous with diuretic. It is only needed when patients are volume overloaded. And although Tom didn't emphasize it, many patients get cardiorenal syndrome because they are on BID doses of Lasix for no reason. Patient is dry like a prune, and particularly elderly patients, and they continue on this diuretic. So that is not recommended. You see that only in volume overloaded patients, it's an expert opinion. Level of evidence C means it's an expert opinion. No trials ever shown to improve survival or improve clinical condition, clinical symptoms of patient unless they're volume overloaded. In African American patients, for the reasons I just showed you, there is level of evidence A and class 1 recommendation to use hydralazine isosorbide dinitrate. Question always comes up whether I should use a fixed dose combination, which is much more expensive, or can I use the generic hydralazine isosorbide dinitrate. I don't think it matters, except it's very difficult for compliance reasons, because then you have to use BID and TID drugs, which becomes very difficult in these patients with already polypharmacy. And then, of course, this is now changed, but clearly class 2 to 4 patients, we should also be using aldosterone antagonists. Level of evidence also very strong, class 1A, level of evidence A. And I won't go through this detail, but this is something available to you if you want to look at, every time you look at different therapies, but you can see most of the drugs recommended are 1A, which are RAS blocking drugs and beta blockers. And this is beta blockers, again, 1A, hydralazine isosorbide, only in African American patients who still are symptomatic on standard therapy. Not everybody needs to be put on that. If they are symptomatic on standard therapy, then you can start them on hydralazine isosorbide dinitrate as well. And certain things are not indicated. You heard about it before, that these over-the-counter supplements, omega-3 fatty acid, there is only one study that showed some benefit, the GISI heart failure trial, but most studies have not shown. And statins, which have been used by many in this setting, are only indicated if there is a primary indication for a statin. Statins otherwise do no good in heart failure patients. And similarly, the calcium channel blockers are generally contraindicated in heart failure patients. So you can see here, this is the evidence-based treatment of heart failure from the Target Heart Failure program that was started by AHA. It has many elements, and you will hear a little bit more about it later on, about the importance of education, disease management center, and performance improvement criteria in heart failure. These are very, very important because despite the guidelines, many patients are not getting appropriate treatment. And such therapy, when given properly, has significant benefit. So here you can see here that relative risk reduction by each one of these therapies, and if you add it all together, you really reduce the heart failure patients' morbidity and mortality by almost 70%. This has been well documented in the trials as well as in the project called Target Heart Failure. How about stage C heart failure with preserved ejection fraction? This is increasing because of the elderly population, because of increasing number of patients who survive post-hypertension, and we don't have very good drug for it at the present time. And it has been concluded based on a lot of different studies that despite increasing population with heart failure with preserved ejection fraction, this to those who are not used to this new terminology we have adopted now, it's the same thing as diastolic heart failure. There is actually no specific diagnostic criteria. We do echo, we can find diastolic dysfunction, but that's not heart failure with preserved ejection fraction, that's diastolic dysfunction. And I mention this again because in our own teaching center, I see a lot of residents, the moment they do an echo in 65, 70-year-old person, evidence of diastolic dysfunction, they label that patient with diastolic heart failure. Heart failure is a clinical syndrome. It is not an echo diagnosis. That's the number one thing to remember. And number two thing is diastolic dysfunction is very prevalent now with aging of population. 60, 70% of the echoes we do in our echo lab have some evidence of diastolic dysfunction. So please do not diagnose them with diastolic heart failure unless they have associated clinical signs and symptoms. And it is, in summary, it's more common in women because they live beyond elderly years more frequently with hypertension, elderly, obese, diabetic patient, and those who have concomitant hypertension, LVH, etc. Annual mortality is now thought to be very similar. You saw the data from the Olmsted County, Maggie Redfield, and Canadian data that show very similar poor outcome in both groups of the patient, but unfortunately we don't have very good clinical trial data to suggest a specific therapy that alters prognosis in these patients. So here you can see the prevalence of patients who have heart failure. This is from the cardiovascular health study that I was mentioning to you earlier, a study of all people above 65 years of age in this NIH-supported study. And you can see that 2/3 of the women with heart failure have diastolic dysfunction or so-called normal ejection fraction, and 42% of the men have the same thing as well. And the prognosis, as I already showed you, and you saw the data earlier from the Minnesota database, is very, very identical in these patients as well as in those with reduced ejection fraction. And there have been many attempts to find the drugs. This is one of the largest study, 4,000 patients done by my good friend Barry Massey from our own VA Medical Center in San Francisco, a multi-center international study, and showed no benefit of treatment with irbesartan, which we thought would work, but it didn't do any good. And actually what they found from this study was the only benefit that was there in high-risk patients was when the blood pressure was reduced more significantly. So again, a resounding message for patients with heart failure with preserved ejection fraction, you must really control their blood pressure even after they have heart failure, and certainly you can prevent development of heart failure before by controlling blood pressure. And when you look at the guideline recommendation, you can see here, look first of all here, level of evidence, not one level of evidence, that's A, because there are not very good clinical trials done that have shown benefit. But the first recommendation is control systolic and diastolic blood pressure as indicated in published guideline. And this will obviously change with the sprint. That will be controlling blood pressure to as low as the patient can tolerate rather than the old concept we have. Diuretics should be used for relief of symptoms due to volume overload. They are probably the best agent in patients who is symptomatic because they instantaneously relieve their symptoms. And other conditions that we just treat the underlying conditions, such as coronary artery revascularization in those who have CAD. Atrial fibrillation is very important because when diastolic heart failure patient develop atrial fibrillation, they can immediately go into pulmonary edema, and certainly controlling their rate would be highly beneficial, or preventing atrial fibrillation by ablation in appropriate people could be beneficial as well. We use the drugs such as beta-blocking agents, RAS-blocking agents, but there is really no good evidence suggesting that they really improve outcome in these patients. Nutritional supplements are not recommended again, like in reduced heart failure. And I mention this because I see a lot of people recommending various kind of coenzyme Qs and fish oil, etc., there's really no benefit. One should keep that in mind. Now, the latest study in this area is the TopCat study. We were part of it with Bert Pitt, the NIH study that was hoping that because aldosterone is so involved in myocardial fibrosis, perhaps blocking its effect on heart might have beneficial effect. It did not show any beneficial effect in the trial overall. However, there were problems with the trial. So here you can see that two different areas. This is North America, Brazil, and Argentina. You can see here, if you look at this particular set of curves, those who are on spironolactone, you see some evidence of efficacy, about actually 18% reduction in the primary endpoint. However, when patients were looked at in Russia and Republic of Georgia, you can see that you cannot rely on their diagnosis like everything else. And clearly you can see here that they just entered these patients in the study without any evidence of heart failure. This was later on proven as well, because when they looked at the BNP that was done in some of these patients, their BNPs were more normal than, of course, mostly abnormal BNPs in these countries, and that's there. So when we do the trials, multi-center international trial, we have to be cautious about interpreting these results as well. So I'll leave you here that we have many, many drugs that are available. We are treating them with these drugs that provide significant benefit, and yet we still have patients who remain at residual risk. So you can see here, despite the standard therapy, the latest trial being with the Plarinone, many patients still have 10 to 20% event rate per year or in 2 years, and the newer therapies that you're going to hear from Dr. Tang provide further benefit in these patients. Thank you very much for your attention. Yeah, I'll be happy to take any questions. Dr. Doshi? Yeah.
Yeah, what's your recommendation for patients to present with acute decompensation and they are either on beta blocker or they are naive to the beta blockers?
Right. So number one, let me tell you that when you talk about acute decompensated heart failure, number one cause for acute decompensated heart failure is also uncontrolled hypertension, believe it or not, despite all the messages that are there. So of course, if that's the case, you treat their blood pressure aggressively. But let's take other group that has controlled blood pressure and other things, and they are not on any therapy. Well, first of all, any patient who comes in with new heart failure will be acutely decompensated. So the first therapy in those patients in hospital is always slowly start them on ACE inhibitor. And I say slowly because their RAS system is overactivated. Whenever you have acute heart failure, you have overactivated RAS system. So what you need to do is start them. What we do, I'll tell you, is we start them on the first dose of captopril, 6.25. Next dose, 12.5 for 2 days. Then we increase it to 25 TID. And before they go out of the hospital, we put them on a long-acting ACE inhibitor. We don't start them on beta blockers in acute decompensated state. We wait till they come back to the clinic. If they are on optimal dose of RAS blocking drug, then we start slowly again the beta blocker, starting at the low dose and up titrating it every 2 weeks. You cannot, when beta blockers were introduced in the clinic, many patients came in with acute pulmonary edema because they were put on target dose right away. You cannot do that. It's the adaptation and resensitization of beta receptors that occurs probably over 2 or 3 months period. And this is why some people, when they do echo right away after starting beta blocker, they say, oh, the ejection fraction has gone down. That will happen because this remodeling, positive remodeling effect of beta blocker takes some time. So it starts low and goes slow. If they're already on beta blocker, then if they're not on RAS blocking drug, then you can start them on RAS blocking drug, as long as their renal functions are not too bad and as long as their blood pressure is okay. You don't need to worry about low blood pressure. We start people on ACE inhibitor or RAS blocking drug even with low blood pressure because if anything, that will increase the blood pressure by reducing afterload.
But you will continue the beta blocker?
Oh, absolutely, yeah.
Yeah, question on the heart failure with preserved ejection fraction. So no one knew how to treat it, so we suggested slow the heart rate down, increase diastolic filling time, maybe give something with a negative inotropic effect like diltiazem or verapamil.
No, never.
So there's no use for that.
No, big no. There is no evidence anywhere. And even in patients with atrial fibrillation, we try to avoid that. If anything you have to use, I would suggest use beta blocker there.
Question,
Yes.
couple of questions. Now, in diastolic heart failure, what's the cause of it, and if, especially when the patient have a normal ejection fraction?
Well, diastolic heart failure by definition has to have normal ejection fraction. If they don't have normal ejection fraction, then
So what's the cause, underlying cause?
number one cause is hypertension.
Even in diastolic,
Well,
right?
mostly in diastolic, but also in systolic, there are different mechanisms. As I showed you in the diagram from Dan Levy's group, in diastolic dysfunction, it is direct pressure load hypertrophy that decreases compliance of the ventricle and causes heart failure eventually. In systolic dysfunction, it's the damage eventually. So systolic dysfunction due to hypertension doesn't occur as early as diastolic dysfunction. It's the damage to the ventricle leading to remodeling and then LV dilatation and systolic heart failure. They're two different processes, but related to the same disease, yes.
What about the role of stress or mental hygiene in the
That's beyond my understanding. Stress plays a role in everything in life, but I really can't tell you that there is a specific. Now, I showed you, just to be more pointed to that catecholamines that are released in response to stress are damaging to the heart, but it's the persistent stress, and that could be a link, if you will, to stress.
How about role of statin?
Statins are not indicated in heart failure based on 3 major trials that have come, unless there is a primary indication. If somebody has underlying coronary artery disease, which we showed from the TNT heart failure trial, in them when you use statins, it reduces the risk of heart failure hospitalization and mortality, but that's by preventing further ischemic event, not by having any specific effect on myocardium. Yes?
I'm just asking this out of curiosity. Due to the prevalence of cancer right now, in your practice or in your experience, to what extent does cardiotoxicity due to chemotherapy contribute to the attributable risk to heart failure, and would that affect the management of the patient?
Yes, most definitely. I think that is becoming an increasing etiology, if you will, particularly breast cancer treatment and certain other cancers. And there is now a specialty of cardiac oncology that deals with predominantly cardiomyopathy that occurs due to adriamycin and many other new anti-cancer drugs. So I think it's something to be cautious. There was a paper 2 weeks ago that showed using of candesartan, which is an ARB, can prevent or reduce the risk of heart failure due to these chemotherapeutic agents. So there is a lot of research going on in that area. And what we suggest is any patient that is going through some of these drugs that cause cardiomyopathy, you should always get a baseline echocardiogram. That's a standard actually by oncology teams now, and then follow it up with subsequent early repeat echo, probably in 3 months or so, even if the patient is asymptomatic, because earlier detection is the best way to prevent the chemotherapeutic agent-induced cardiomyopathy. Yes, sir?
I had a question about use of particular beta blockers in diastolic heart failure. Is there any advantage of choosing metoprolol succinate over carvedilol, or is there no difference?
There is actually no specific study in patients with heart failure, preserved ejection fraction, or diastolic heart failure that has compared it. But I would suggest, if one of your goals is to control heart rate appropriately, use drug like metoprolol succinate because it has a 24-hour efficacy versus carvedilol, unless you're using the new extended release, which we have no experience in heart failure. But the shorter acting ones, again, has the problem you have to use BID, and it may have mini beta blocker withdrawal phenomenon. Yes?
Do you think there's any role at all for the use of peripheral alpha blockers like prazosin, especially if the patient has renal failure?
No, we showed that in the vasodilator heart failure trials done in the VA, that prazosin, although originally thought to be beneficial, it over time develops tachyphylaxis or tolerance, so it is not beneficial. Okay, any other questions?
Thank you very much.
Thank you.